Neurodegenerative disorders. Neurodegenerative disorders are a group of progressive conditions that primarily affect the brain and nervous system, often presenting with cognitive impairment as a key feature. In the early stages, it can be difficult to distinguish between normal age-related memory changes and the onset of a mild or major neurocognitive disorder. Understanding the differences between these conditions is essential for accurate diagnosis and effective management. Normal aging typically occurs in individuals over the age of 60 and is characterized by a normal mini-mental state examination, MMSE score, usually above 27 out of 30. People may experience minor difficulties with executive function, such as attention span, problem solving, or learning new information. Word-finding difficulties, also known as mild expressive aphasia, are common, and individuals often exhibit an advanced sleep-wake cycle. For example, go to bed early around 7 p.m. and waking up around 3 a.m. Importantly, despite these changes, there is no significant loss of functional ability in activities of daily living, ADLs, or instrumental activities of daily living, IDLs. A mild neurocognitive disorder represents a noticeable decline beyond what is expected from normal aging. It involves deficits in at least one cognitive domain, such as executive function, perceptual motor skills, language, learning and memory, social cognition, or complex attention. The MMSE score is typically between 23 and 27 out of 30. Although patients may retain independence in basic daily activities, they experience some limitations, particularly with more complex tasks such as managing finances, cooking, or driving. A major neurocognitive disorder, also known as dementia, involves a significant decline in one or more neurocognitive domains and is usually reflected by an MMSE score below 24. Functional independence is lost, and patients require assistance with ADLs and IDLs. The most important risk factor for dementia is age. The classic 4 As of dementia help in clinical recognition. 1. Amnesia, progressive memory loss, or forgetting recent and past information. 2. Aphasia, language impairment, including forgetting words, struggling to communicate, or pretending to understand. 3. Apraxia, inability to perform pre-programmed motor tasks despite intact motor function, leading to difficulties in eating, dressing, using household items, or driving. 4. Agnosia, inability to recognize familiar objects or people. This can manifest as visual agnosia, not recognizing faces, auditory agnosia, failing to identify familiar voices, or alexia, difficulty reading or understanding written language. Sensory interpretation problems may also lead to incontinence or irritability due to unrecognized bodily sensations. It is important to differentiate dementia from delirium. Delirium has an acute onset, fluctuating course, and involves a change in level of consciousness. It is typically reversible once the underlying cause is treated, and the EEG in delirium shows an abnormal, acutely sick brain pattern. In contrast, dementia has a chronic and gradually progressive course, with no change in consciousness level, and the EEG remains normal. When evaluating suspected dementia, clinicians must first rule out reversible causes through a comprehensive assessment. This includes a detailed history, focusing on medications and social circumstances, such as bereavement that may cause pseudodementia, along with physical examination and laboratory tests. Important investigations include a complete blood count, CBC, thyroid function tests, vitamin B1 and B12 levels, metabolic panel, and screening for infections such as syphilis, VDRL test, and HIV. Brain imaging with CT or MRI is recommended to detect structural abnormalities. Reversible causes of dementia include hypothyroidism, neurosyphilis, or HIV dementia, depending on stage and treatment, vitamin B12 or B9 deficiencies, thiamine deficiency from alcohol use leading to Wernicke aphasia, medication effects such as benzodiazepines or anticholinergics, normal pressure hydrocephalus, pseudodementia, and chronic subdural hematoma from falls causing bridging vein tears. Irreversible causes include Alzheimer's disease, vascular or multi-infarct dementia, Parkinson's disease dementia, Lewy body dementia, Huntington disease, frontotemporal dementia, unresectable brain neoplasm, Wilson disease, progressive multifocal leukoencephalopathy, PML, prion diseases such as Creutzfeldt-Jakob disease, neurosyphilis or HIV dementia, late stages, and thiamine deficiency from alcohol abuse leading to Korsakoff syndrome. Dementias are progressive, chronic neurodegenerative diseases characterized by the continuous degeneration and loss of neurons in the brain. Early recognition of presenting features is essential for accurate diagnosis, as middle to late symptoms of various dementias can overlap significantly. Understanding the distinct patterns of onset, clinical presentation, pathology, and imaging findings is crucial for differentiating among the common types of dementia. Alzheimer's disease is the most common form of dementia and presents with a gradual onset of early memory impairment. The pathologic findings include extracellular neuritic plaques composed of amyloid beta, trapping, degenerating neuritic processes, and intracellular neurofibrillary tangles formed by hyperphosphorylated tau proteins. Additionally, intracellular Hirano bodies, rod-shaped aggregates of actin and associated proteins, particularly in the hippocampus, are observed. Imaging with MRI or CT reveals diffuse cortical atrophy, most prominently in the temporal and parietal lobes, along with hippocampal atrophy. This leads to hydrocephalus ex vacuo, characterized by ventriculomegaly that is proportional to increased sulcal size due to cortical volume loss. Vascular dementia presents with a stepwise, abrupt decline in cognitive function following each overt or subclinical stroke. The underlying pathology involves multiple infarctions affecting various regions of the cerebral cortex and subcortical structures. Brain imaging demonstrates evidence of old infarctions, including lacunar infarcts and extensive deep white matter changes secondary to chronic ischemia. This form of dementia is associated with atherosclerotic disease and small vessel pathology, and symptoms often depend on the areas of the brain affected. Frontotemporal dementia, also known as Pick disease, is characterized by a gradual onset of early personality and language changes rather than memory loss. Pathologic examination reveals neuronal intracellular accumulations of ubiquitinated TDP-43 proteins and Pick bodies. Imaging studies show unilateral or bilateral atrophy of the frontal and/or temporal lobes, leading to hydrocephalus ex vacuo. Functional imaging, such as fluorodeoxyglucose positron emission tomography, FDG PET, demonstrates frontotemporal hypoperfusion and hypometabolism, supporting the diagnosis. Clinically, patients exhibit disinhibition, apathy, loss of empathy, and speech or language difficulties, depending on the dominant affected lobe. Normal pressure hydrocephalus presents with a gradual onset of the classic triad of gait ataxia, urinary incontinence, and cognitive impairment, often described as wobbly, wet, and wacky. The pathophysiology involves decreased cerebrospinal fluid, CSF, absorption, leading to accumulation and expansion of the lateral ventricles. This ventricular enlargement stretches the corona radiata, disrupting motor pathways responsible for gait and continence. MRI is preferred over CT and reveals ventriculomegaly without cortical atrophy, meaning the sulcal size remains normal. This differentiates normal pressure hydrocephalus from other dementias associated with cortical volume loss. Creutzfeldt-Jakob disease, CJD, is a rare, rapidly progressive dementia characterized by abrupt cognitive decline and startle-induced myoclonus. It is caused by prion infection, leading to spongiform degeneration of brain tissue. Diagnostic testing includes real-time quaking-induced conversion, RT2IC, which detects prion proteins. MRI using diffusion-weighted imaging demonstrates increased T2 and FLAIR signal intensity in the putamen and caudate nuclei. EEG findings show periodic sharp, triphasic synchronous discharge complexes, which are characteristic of CJD. The disease typically progresses over weeks to months and is universally fatal. Dementia with Lewy bodies is a gradually progressive dementia, though more rapid in course than Alzheimer's disease. It is characterized by visual hallucinations, daily fluctuations in cognition, Parkinsonism, and REM sleep behavior disorder. Pathologic findings reveal round, eosinophilic cytoplasmic inclusions composed of alpha-synuclein, known as Lewy bodies. When these inclusions are found in the cerebral cortex, the condition is termed dementia with Lewy bodies, DLB, whereas subcortical or midbrain involvement corresponds to Parkinson's disease dementia. MRI imaging reveals cortical atrophy with relatively limited hippocampal atrophy compared to Alzheimer's disease. Clinically, DLB is distinguished by its prominent visual hallucinations, cognitive variability, and early Parkinsonian motor symptoms. In summary, key fact: HIV-associated neurocognitive disorder, HAND, occurs in HIV/AIDS patients regardless of treatment status. It results from HIV-infected microglia in the CNS. Diagnosis is by exclusion. Early signs include mild cognitive impairment progressing to dementia. Treatment is antiretroviral therapy. Avoid efavirenz due to CNS side effects. Alzheimer's disease is a chronic, progressive neurodegenerative disorder and the most common cause of dementia, accounting for approximately 66% of cases. It results from the degeneration of cholinergic circuits leading to diffuse cortical and subcortical atrophy, with hippocampal degeneration being the hallmark feature responsible for recent memory impairment. Age is the most important risk factor for sporadic Alzheimer's disease, as 95% of patients are older than 65 years. Genetic factors also play a role. The apolipoprotein E gene can be harmful or protective. The epsilon-4 allele promotes amyloid precursor protein conversion to amyloid beta, which is pathologic and increases the risk of Alzheimer's disease, while the epsilon-2 allele promotes amyloid alpha formation, which is non-pathologic and protective. The higher the number of epsilon-4 alleles, the greater the risk. Early onset Alzheimer's disease, which occurs in less than 65 years of age and accounts for about 5% of cases, is usually familial and associated with mutations in the amyloid precursor protein and presenilin 1 and 2 genes, as well as with Down syndrome, since the AP gene is located on chromosome 21. Clinically, Alzheimer's disease presents with progressive neurocognitive dysfunction. Degeneration of cholinergic circuits to the hippocampus causes early declarative episodic recent memory impairment, which is the earliest and most important clinical finding. As the disease progresses, continued cortical and subcortical degeneration leads to worsening memory loss, including long-term memory. Early to intermediate findings include executive dysfunction, such as impaired judgment, problem solving, and poor work performance, as well as visuospatial impairments, such as getting lost in familiar areas and language difficulties, including naming, comprehension, and fluency issues. Other cognitive domains are affected in intermediate to late stages. Behavioral and psychiatric manifestations typically appear in the middle to late stages of the disease, with personality changes, apathy, social withdrawal, irritability, aggression, and psychosis being common. Incontinence and motor dysfunction, such as apraxia for learned motor tasks, occur in the late stages of Alzheimer's disease and are not seen early in the course. A helpful mnemonic to differentiate Alzheimer's disease from normal pressure hydrocephalus is DUM versus MUD. In Alzheimer's disease, the order of symptoms is dementia first, followed by urinary incontinence, and then motor symptoms, DUM. In normal pressure hydrocephalus, motor dysfunction, typically gait ataxia, occurs first, followed by urinary incontinence, and then dementia MUD. Diagnosis of Alzheimer's disease is primarily clinical but supported by imaging and pathology. MRI or CT imaging shows diffuse cortical atrophy, particularly in the temporal and parietal lobes, with marked hippocampal atrophy and resultant hydrocephalus ex vacuo, due to volume loss. Pathologic findings include extracellular neuritic plaques formed by amyloid beta entrapping neuritic processes, which may lead to cerebral amyloid angiopathy and lobar hemorrhage. Intracellular neurofibrillary tangles composed of hyperphosphorylated tau proteins and intracellular Hirano bodies, which are rod-shaped aggregates of actin and associated proteins, especially found in the hippocampus. Treatment for mild to moderate Alzheimer's disease involves acetylcholinesterase inhibitors such as donepezil, galantamine, or rivastigmine. These drugs address the widespread cholinergic deficiency by increasing synaptic acetylcholine levels, leading to modest improvement in cognitive and global functioning, though they do not alter disease progression. Common adverse effects include nausea, dizziness, and insomnia, as well as other cholinergic side effects. Anticholinergic medications should be avoided because they can worsen cognitive impairment. Vitamin E supplementation may be used for its antioxidant properties in mild to moderate dementia, though evidence for its benefit remains inconclusive. It is often used due to its safety. In moderate to severe cases, memantine, an NMDA receptor antagonist, is added to reduce glutamate-induced excitotoxicity, providing neuroprotection and slowing progressive symptomatic decline. Its side effects include dizziness, confusion, and hallucinations. Vascular dementia is a form of dementia associated with a history of stroke or cerebrovascular disease and is the second most common type of dementia after Alzheimer's disease. It results from reduced blood flow to the brain, leading to ischemic damage and cognitive decline. Clinically, vascular dementia presents with a stepwise decline in cognitive function, where periods of stability are interrupted by sudden deteriorations corresponding to new vascular events. Impaired executive function, such as poor planning, judgment, and problem-solving, often occurs before memory deficits. Patients may also exhibit neurological findings consistent with prior strokes, including sensory or motor deficits. Major risk factors include increasing age, hypertension, diabetes mellitus, coronary artery disease, embolic sources, and a previous history of stroke. A key distinguishing feature is the abrupt onset and stepwise progression of symptoms, especially when motor symptoms change suddenly, rather than the gradual, steady decline seen in Alzheimer's disease. Diagnosis is based on the presence of dementia or mild cognitive impairment, along with clear evidence of cerebrovascular disease on history, physical examination, or neuroimaging. The clinical course should show an abrupt or stepwise progression or a clear relationship to stroke, and symptoms must not be better explained by other progressive non-vascular dementias. Treatment follows the same principles used for stroke prevention and management. This includes aggressive control of risk factors for atherosclerotic cardiovascular disease, such as hypertension, diabetes, and hyperlipidemia, along with lifestyle modification and antiplatelet therapy when indicated. The goal is to prevent further vascular injury and slow cognitive decline. Frontotemporal dementia, also known as PIC disease, is a rare, progressive, and irreversible neurodegenerative disorder that primarily affects the frontal and/or temporal lobes of the brain. It typically presents as an early-onset dementia, most often in individuals in their 50s to 60s, and includes a spectrum of subtypes depending on the regions of the brain involved. The behavioral variant of frontotemporal dementia is the most common form and is marked by early and progressive personality and behavioral changes reflecting degeneration of the frontal cortex. Patients exhibit disinhibition, socially inappropriate behavior, apathy, loss of empathy or sympathy, hyperorality such as binge eating or putting objects in the mouth, and compulsive or repetitive behaviors. Some individuals may also develop motor symptoms depending on the affected areas. The primary progressive aphasia subtype affects the temporal lobes and presents with gradual decline in language abilities. Patients experience speech apraxia, word-finding difficulty, and impaired language comprehension or usage. During the early stages, other cognitive functions generally remain intact. Diagnosis is primarily clinical and supported by imaging studies. MRI typically shows unilateral or bilateral frontal and/or temporal lobe atrophy, leading to hydrocephalus ex vacuo. FDG PET scans reveal frontotemporal hypoperfusion and hypometabolism. Pathologic findings include neuronal intracellular accumulations of ubiquitinated TDP-43 proteins and, in some cases, PIC bodies, spherical aggregates of hyperphosphorylated tau proteins. Treatment is supportive only, as no disease-modifying therapies currently exist. Management focuses on alleviating symptoms such as depression, agitation, and insomnia, and providing caregiver support and behavioral interventions. Normal pressure hydrocephalus, NPH, is a rare but potentially reversible cause of dementia that typically affects adults over 60 years of age. It is a chronic form of communicating hydrocephalus caused by decreased cerebrospinal fluid, CSF, absorption, leading to increased CSF volume and ventricular enlargement. This expansion stretches the corona radiata, resulting in the classic triad of gait disturbance, urinary incontinence, and dementia. NPH can be idiopathic or secondary to conditions that damage the arachnoid granulations, such as meningitis or subarachnoid and intraventricular hemorrhage. Clinical case. A 71-year-old woman is brought to her primary care physician's office by her son, who is concerned that she has had worsening recent memory, difficulty participating in her daily activities, restlessness, and difficulty sleeping for the past year. She scores a 22 on the Mini-Mental State Exam, MMSE. What is the most likely diagnosis? Alzheimer's disease is the likely diagnosis. The key differences between Alzheimer's disease and normal aging are that in normal aging, patients can perform their activities of daily living, complain of memory loss, yet provide detailed information about their forgetfulness, and have a score greater than 27 on the MMSE. NPH is characterized by a normal opening pressure on lumbar puncture. Continuous intracranial pressure monitoring may show normal or intermittently elevated pressure. The increased CSF volume produces regional, rather than diffuse, pressure elevation, which causes symptoms without typical signs of raised intracranial pressure like headaches or papilledema. The classic triad is remembered as wobbly, wet, and wacky. Gait disturbance, wobbly, is the earliest and most prominent symptom. Patients develop a magnetic or shuffling gait that resembles Parkinsonian gait, but without tremor and with preserved arm swing. Urinary symptoms, wet, begin with urgency and frequency and progress to incontinence accompanied by apathy. Dementia, wacky, develops later and manifests as slowed psychomotor activity, poor attention, executive dysfunction, and apathy over months to years. Diagnosis is primarily clinical. The patient does not need to exhibit the full triad, but gait dysfunction must be present. Urinary and cognitive symptoms are confirmed through history and cognitive testing. The best initial imaging study is MRI, which shows ventriculomegaly disproportionate to cortical atrophy, ventricular dilation without sulcal enlargement. The best confirmatory test is symptom improvement following lumbar puncture, where the opening pressure is normal or slightly elevated. The definitive treatment is ventriculoperitoneal, VP, shunting, which diverts excess CSF and relieves symptoms. Key fact: classic triad of NPH in order of onset equals wobbly, gait ataxia, wet urgency incontinence, and wacky dementia. The definitive treatment is ventriculoperitoneal, VP, shunting, which diverts excess CSF and relieves symptoms. A lumbar drainage trial over several days can predict surgical benefit. Patients with predominant gait impairment tend to respond best, while those with advanced dementia respond poorly. Creutzfeldt-Jakob disease, CJD, is the most common prion disease but remains an extremely rare form of dementia. It occurs when an abnormal protease-resistant prion protein accumulates in the brain, causing spongy degeneration, neuronal loss, and astrocytic proliferation. CJD causes a subacute dementia with ataxia and startle-induced myoclonic jerks, with rapid clinical progression that develops within weeks to months after symptom onset. New variant CJD, also known as mad cow disease, is a more slowly progressive prion disease that occurs in younger people with a history of eating contaminated beef or human brain tissue, as seen in Kuru. Iatrogenic CJD can develop after ophthalmologic or neurosurgical procedures, such as corneal transplants due to poor sterilization of surgical instruments. The rapid progression of symptoms and presence of myoclonus help distinguish CJD from other dementias. Definitive diagnosis can be made only by brain biopsy or autopsy, but clinical features, imaging, and laboratory results are often sufficient to make a probable diagnosis. Findings include increased 14-3-3 protein in the cerebrospinal fluid and periodic sharp wave complexes on EEG. Real-time quaking-induced conversion, RT2AC, is a modern test that detects abnormal protein misfolding in CSF samples. Brain MRI typically shows hyperintensity in the caudate and putamen, known as the hockey stick sign or a cortical ribboning pattern. Differential diagnoses include paraneoplastic syndromes, drug-induced encephalitis, and autoimmune encephalitis. A probable diagnosis of CJD is made when there is rapid symptom progression with no other identifiable cause on MRI, EEG, or CSF testing, supported by the characteristic findings. Treatment is purely symptomatic, as there is no cure and disease progression cannot be stopped. Most patients die within 1 year of symptom onset. Lewy body dementia is an umbrella term that includes Parkinson's disease, PD, dementia, and dementia with Lewy bodies, DLB, which are differentiated by the 1-year rule. DLB is the second most common cause of dementia, accounting for 10% to 20% of cases, and typically affects patients older than 65 years, often associated with depression and suicidality. The classic triad includes dementia, Parkinsonism, and visual hallucinations. Dementia presents with executive and visuospatial dysfunction. Parkinsonism involves extrapyramidal motor symptoms described by the mnemonic trap, tremor, rigidity, akinesia or bradykinesia, and postural instability. Visual hallucinations are well-formed and detailed, often involving people, animals, or colorful abstract shapes. Cognitive function, arousal, and attention fluctuate, with patients cycling between baseline and brief periods of confusion resembling stroke-like episodes. Many patients also develop REM sleep behavior disorder, characterized by dream enactment through vocalizations or motor movements during sleep. Diagnosis is clinical and guided by the 1-year rule. Dementia with Lewy bodies is diagnosed when cognitive impairment occurs before or within 1 year of Parkinsonism onset, whereas Parkinson's disease dementia is diagnosed when cognitive decline develops more than 1 year after Parkinsonism. MRI may reveal cortical atrophy with limited hippocampal atrophy, distinguishing it from Alzheimer's disease. Pathologically, PD, PDD, and DLB share around eosinophilic inclusions of alpha-synuclein, known as Lewy bodies, found in cortical neurons in DLB and the basal ganglia in PD and PDD, representing a disease spectrum. Treatment involves acetylcholinesterase inhibitors, such as donepezil, galantamine, and rivastigmine for cognitive symptoms. Parkinsonian features are treated similarly to PD, but with lower doses and slower titration to avoid worsening hallucinations or psychosis caused by increased dopamine levels.